joining us today. I think they have a prior conflict, so, but I don't think we had anybody else who did not, who declined, so,
Okay, I'm about to have us go live on YouTube in just a second.
okay. Hold off just 1 second if you could, and I sent Tony in a text. It may be a very short call if it's just the four of us. I don't know.
And Melissa, I'm going to be away next week, but I am going to try to join.
Okay, fabulous. So Barb, if you're looking for a reason to break away from your family duties, I'm happy to catch up with you or talk. So it's up to you, but I know you'll have other things going on. So
I will send you an email kind of once I do the landscape of what
yep.
my obligations are
Okay.
going to be. And
Fabulous.
I suspect I know I'll be getting on my computer every day.
Right. Okay. I did text Tony Ann to let her know we were on the call. I have a feeling probably something came up. Regina, what is it? What information would you be sending out just out of curiosity?
Sending out to the group
Yeah.
in terms of my absence.
Oh, no. Just, I think you had said you wanted to send out some information.
No. I said I was
Oh,
just going to notify the group that I
oh,
will be
fabulous.
away.
Okay,
Yeah.
that's
But
fine.
but you said you will send the email out.
Yes, I will. I
Understand.
absolutely
Okay.
will.
Okay.
Yep. Well, this may be the shortest call in history. I'm going to put myself on mute and call Tony in.
Hi, Melissa.
Hello. We're still waiting for a couple of folks to dial in, so it may be a short call because we don't have as many people on today's call. But we are being live streamed right now and recorded, so just for everybody's awareness.
Great. Thank you.
Mhm. I'm going to put myself on mute for just 1 second. Hey, Tony, and it's Melissa. We only have Barb, Eileen. So I'm going to start just because we want to be careful and mindful of people's time. And thank you for those of you who are able to join. We had a couple of folks who are not able to dial in. Um, we're in the throes of preparing draft for the report, so there's a lot of activity going on. It still needs quite a bit more work, and we're going to be reaching out to people individually to get your help, just filling in the gaps and preparing things. One of the biggest things I think we wanted to do, and I'll do a screen share on this one, is focus on the goals. Let me just pop up this one slide here, because we do have, where are we, Zoom? You just, sorry. I'm sorry, I'm getting distracted by technology. So you'll see this, and let me see if I can put it in presentation mode. Maybe not. Can you see my screen? Maybe not yet.
We can see it, Melissa.
Oh, you can. You
Yes,
can.
yes.
Fabulous. All right. Let me just go back to this slide. And I thought it would have been presentation mode, which would be easier for you to see. But Barbara, to your point the other day, the assembly proposal got converted to a public act. And in the act, and I won't read this, but it sets forth a couple of basic elements. We're supposed to review services, hospice and pediatric patients, make recommendations for levels of hospice services, and evaluate payment and funding options, which really goes to what do we ask the assembly for in terms of funding for our proposed pilot. And then in our report, there's a number of things that we're supposed to be responding to. The funding is kind of a number one. Requirements in order to make a pilot go live. So whether it's staff or resources, facilities, but we need to identify what those requirements would be. Education, and these are things I think that they're, when they revised this, they reported back on some of the things we were proposing from last year. But education curriculum return requirements, and then licensing and certification requirements. And I know we've done quite a bit, we as a group have done quite a bit of work and had a lot of discussions around a number of these to-do items. But throughout our calls, we've talked about a couple of things, and I'll go to the bottom of the screen here. Increasing the number of RNs, both sponsoring training for the RNs, and I think we're reverting back to the Egan School of Nursing, and then funding shift nursing hourly rates, because we know that they're woefully behind what it would take to attract nurses to do the shift nursing work. So those are two elements around nursing. And Eileen, will want your expertise on how to in terms of these elements, not necessarily the shift nursing, but certainly the education and the practicum with hospice. And I'm just going to go through the list, and then we can open it up for others to respond. We talked about expanding access to Medicaid, considering a state plan amendment, removing or broadening the 6-month hospice medical requirement to give us more flex on how do we treat patients in a more meaningful way, and that would include obviously palliative, kind of combined palliative and hospice care, and increase the Katie Beckett waiver access. And I think Regina will be going back to you to ask quite a bit about that. And then building the pilot, there was discussion last year, and I think the assembly seems to be approving of the fact that we would have a center of excellence approach, and using resources who already deliver in hospice services to pediatric patients. So it would be groups like Regional Hospice, Connecticut Children's, Egan School of Nursing for the nursing care pieces, Yale New Haven Hospital. So organizations that have that footprint already. And also broadening it, the access to these organizations beyond just the ones we know that do the core work in this area. So kind of tiering out our expertise in those things just to begin to expand capacity in other organizations. creating customized education for families and practitioners. So there would be two different views on that, but knowing that each of these audience needs a little bit of a different slant on what they would receive. But in order to, so that they could both deliver services, help coordinate, and make good decisions. Establishing the baseline certifications and licensures. And I know Barb, your the working group that you're part of has been working to build that out, but we'll want to report back on that. Also building tools, virtual tools. So having a web presence, interactive communications for families and practitioners as well. And offering coaching for families in terms of, maybe we need kind of case management support. We need to have our practitioners tiered up so that they can guide families to good decisions. So those were some of the core things we are looking at to propose as part of this pilot organization. And Tony and I just kind of went through the goals that we've been talking about and relating them back to what the Public Act is asking us to do.
Yes, and you just keep going because you're doing a great job. And I think from here, we're going over this agenda. And from now on, this is just going to be a work-related mission. So just keep going, Melissa.
Okay. I think let me stop for a minute. Is there anything, are there anything in these goals that we should not be doing or that we need to do, say, differently? And we're going to come back to each of you. I'd say probably Tony Ann and I are going to come back to each of you to get more granularity on these. And are we missing anything that would be mission critical to having a pilot for calendar year 2026 and probably spilling over a little bit into 2027?
And I think also when we look at a pilot program, what exactly are we talking about, right? Like what does a pilot program look like? Because is it a pilot program for the education part of it, or is it a pilot program for an agency to be doing, pediatric and palliative care when pediatric hospice and palliative care when we have that already? So what are we piloting, so to say?
I think. I'm sorry.
Go ahead.
No, go ahead, please.
I was just going to say, I think a lot of the onus is going to be on regional, especially seeing that we were given, state money to expand our program. We don't need a pilot program to do pediatric hospice and palliative care. So I think determining piloting what is, and I know we kind of have it in there. And it's, pilot program, not limited to staff and facility requirements. Yes. Pilot program providing, there was one thing on here when I looked at it this morning that I was going to say, like, that's something that we could pilot. What we talked about establishing levels of care. Well, there are 4, right? They're established. I'm thinking maybe the establishment of what palliative could actually look like. But, I'm going on and on now, but this is how, my brain goes, and these are the things that we really have to start figuring out. But you keep going, Barb.
Well, I think some of these things that they're going to be simultaneous, right? But some will be in a much more mature phase. So we know that regional hospice already provides this type of care. We already know that Connecticut Children's or Yale New Haven Children's Hospital already provide concurrent and palliative care to children. So some of these things will be more mature. I think future execution on some of these things for other organizations might be at the entrance phase. At the same time, for example, building out virtual tools, beginning to build education, those are going to have to start from scratch. But we should start the minute we get approvals on these things, start to build these things out so that, because it will take us a while to get these things created and built out. I was just looking at the website the other day, how to build a website. And there are practitioners out there who know how to do this, but there are ways we can build out some of these resources to make them more accessible to families and practitioners. So, and everybody on this team over the course of the next year, assuming we get approval for this, will be able to weigh in on looking at the website saying, yes, this works. No, we need more of this. So I think there's a phased approach given any one of these elements. But I think if we start, assuming we get the approval and we can get the appropriate funding, we need to start and assess what's the maturity phase of those things, where do we start, and having a timeline to proceed for each of those work streams.
I see
Eileen,
Yeah,
Eileen
go
and
ahead.
Barb.
A couple of points. So first, I know you mentioned regional and our two acute care children's hospitals. I believe the biggest issue is in the community, that we don't have resources for people to live at home. We don't have nursing, we don't have social work, we don't have financial. So it's not that there's not expertise in our state, it's contained to our acute care facilities, and then it's held back in our hospice facilities, right? Because of the 6-month prognosis, because of financial reimbursement, because of the lack of insurance, private pay support, because of the Katie Beckett wait list. So if our focus is community-based palliative care, and education is a tremendous barrier or lack of. I think, as Melissa was saying, this needs to be worked on in multiple facets. Happy to work offline with Egan's involvement, and to develop a potential workforce initiative, if that's plausible and feasible and all parties agree. However, I think the insurance and the reimbursement is a significant part of it. So we can't do one without the other, in my eyes.
Right.
And in talking about the website, does it make any good sense to assess what we have already with the coalition? What types of virtual tools are you looking to curate? We have website infrastructure through the Pediatric Palliative Coalition of Connecticut. We have infrastructure, we have capacity, but what types of virtual tools are you looking for? Could we carve out a section of that website for more information, so it doesn't have to start from scratch, where we don't want to duplicate our efforts. We want to expand our efforts? Or is there something on DPH that we should be building out, where they have infrastructure, versus creating something new and spending something new, spending more money in an area that we might already have those services? However, it would be suggested and recommended that we grow the website platform in some fashion. If someone could tell me more about virtual tools.
So
but Melissa, before you even go into like virtual tools, for me, and I agree with you on everything that you said, and even with the idea of doing a pilot program to me would be, we're piloting it once palliative has a better payment structure. We're piloting it once we have a mandate for insurances. I mean, to say we're piloting a program right now with none of the barriers to go away, we're just doing our everyday business. We're not piloting anything. So that's where I keep going back to, and if I remember correctly, when we first talked about a pilot program or a center of excellence, it was strictly around education. It was education and where are these nurses going to go get the rotation through, palliative, pediatric palliative or hospice. There's nothing to pilot because none of the barriers are gone. So we're still in our same, situation. I would say that we could get closer to building that center of excellence for education. I mean, I can't imagine that Yale wouldn't be prepared to do a rotation through, or Connecticut Children's wouldn't be prepared to do. We will take students. So I think that's kind of on the side of a center of excellence that we could build and pilot that. Are nurses getting the training that they need? Are we finding enough nurses that are even interested? So on and so forth. But I agree with you 100%. And when we say, like, the Palliative Care Coalition has a website, but DPH to me, or something on the state level, because if I'm a parent with this, crazy diagnosis, or even trying to start, my first thing would be like looking up state of Connecticut, whatever, what's going to lead them to the right avenues. And I agree, the coalition has done a lot for a website. Can that link into Champion Care? Do we do it through DPH with links to go to the other places? So I agree, wherever we can save money would be great. But I think that, yes, we need to start breaking down, or recommending how to break down some of these barriers to even get us to a point to pilot things any different than we are today.
So I look at myself as the canary in the coal mine. And the reason I say that is all of you have tremendous depth and expertise in all of these different fields. I look at all these different websites, and if I were a parent, I wouldn't exactly know what to do next or how to get the information, even though there is so much amazing information on all these places. And I guess if we are thinking about Champion Care, it's kind of a customized, hand-holding, easy button solution for families to have guided information and guided support, and make that more of the focus, utilizing all the information that's on the Pediatric Palliative Care website, using information from Connecticut DPH, Katie Beckett. So I understand the concern about putting money into something else. The question is, how do we get that guided, customized, hand-holding approach for families and also practitioners to a certain degree to help them make good decisions and know where to get the information? So I just throw that out there.
Yeah, I just want to mention, this is Regina. I just want to mention that in terms of looking at, a hub or a repository of information, what we shouldn't lose track of is also the Info11, because, technically that is where most people go to, to start looking for information. So again, in order not to reinvent the wheel or anything, as we are considering having these talks, we shouldn't lose track of the Info11 website as well.
Okay.
Okay, Info11.
Yeah, it's
Okay.
Info-11.
Okay. And Barb? Thanks, Regina and
Yeah.
Eileen.
Diane, I just wanted to make a few comments. I think if the Center of Excellence pilot program cannot start until we reduce the barriers, we're going to need to identify that or memorialize it in the report, because the legislation is directing that we, I just want to, appropriations necessary to establish the program and the pilot program requirements. So we're going to need to be able to convey to the reader that until such time the barriers, as Eileen has mentioned, and I think we need to mention in here the disparity with payers, that's a real challenge, and what our thoughts are about mitigating that challenge. And that's when we likely want to involve the insurance department or the payers to one of our meetings, or their lobbyist, so that we can start the discussion about parity, so that they may be able to anticipate that something may be coming. And then I wrote notes as the, and in terms of Eileen's comment about the virtual tools, I think, Eileen, we built that in response to one of the family members who had indicated early on that she was so grateful when she made the connection to regional, wish she had done it earlier, but didn't know where to get. And as Melissa has so eloquently stated, there are so many resources out there, but where do we find them? We need to have a one-stop shopping resource. And again, Regina, 211, the info line is great. But I think there needs to be some duplicative efforts here so that we do socialize that there are resources out there. And I love your coalition website, and we could always build on that.
Yeah.
And my last point was, I just loved when Dr. Moss said at our last meeting, because I wrote it down, and I think that needs to be an overarching mission that we state in our report, is that by the end of 2027, no child will die in the home without supports. So we need to start pulling in home care and hospice agencies as well. And I know Tracy's on our group, but they are critical, because more patients, families, individuals, I think, choose now to live their final days in their private setting rather than a clinical setting.
Right.
Thank you.
Thanks, Barb.
Can I tack on to that? Thank you, Barb, for everything you just said. A couple of things. Not to forget, Tony, and we are a state coalition. So we're a Connecticut organization.
Right.
And whether we cross-reference one another, I think is a great idea. Again, getting back to what the virtual tools are, we're about to begin a parent group who has been very verbal about the lack of connectivity that they have for resources. I could see the coalition housing that piece of it, not to say that it can't be somewhere else, but saving time and money and efforts is something I'm always keyed into. That's one thing. And regarding the dying in the home, and looking at workforce, that probably goes back to education as well. And looking at current workforce who I believe have the license to do so. So I'm not certain of what this barrier is, other than they're uncomfortable, which again, I believe can be mitigated in somewhat with education and mentorship. So I think that is feasible in this timeline. And there was one other point that someone else please take if you have a question, because I've lost my train of thought on the third point.
Well, I was going to say it to what you just said. I don't think, yeah, I don't know that like layering websites on top of websites, or we have one, the coalition has one. That's not what I'm suggesting, but what I am suggesting is what's the easiest pathway there? If I'm a parent of you know, even a recently diagnosed or, you know, whatever, am I going to know to look up the Pediatric Palliative Coalition, or am I going to look up, I've just been told my child is dying in Connecticut, what are my resources? And something come up for that. And what is it? Is it a state resource that then you can link into the coalition? Or, you know, I don't know how the coalition comes up immediately when they're looking that way, because will they understand even what to type in?
So I did, to your point, Tony Ann, about not just knowing what to type in. I did a bunch of different Chat GPT searches. There are just lists and lists and lists of links to national, not as many to state sponsored websites, but that would mean that a parent would have to curate all that information to know, who do I talk to about this and whatever. And I think one of the things we were thinking about is, you know, a personal resource. You know, I think Jessica Pope has the type of job as kind of a case liaison that would be a very valuable thing for us to consider as part of this overall footprint. Someone who could help the families and or practitioners navigate the wealth and the volume of information out there. So both the human touch as well as kind of a web-based touch. And I know that, you know, for example, if there's any number of different apps out there, you could type in something in an app and it'll get you to where you need to go. And so the technology tools exist for us. We just have to understand and decide what works best for what we want to do. Also, to your point about the resources out there, I went and looked at a map of Connecticut and the dedicated resources who have hospice expertise in terms of pediatric hospice expertise all sit in the western part of the state and a little bit in the center part of the state. There's really nothing in the eastern part of the state. There are hospice organizations, but they don't necessarily seem to have the pediatric expertise. So I think we're very geographic heavy on the western part of the state, which is fabulous for those of us who sit in this part of the state, but not so great if you live, you know, over near the border of Rhode Island or Massachusetts in the upper corner. So there's a gap in terms of geography of what's available, in terms of just organizations that have expertise in pediatric hospice.
And when you even say that, like the western part of the state, they may say they have expertise and that they will take pediatric cases. However, they don't. So it's even worse on the western state than it looks like. Forget what you're talking about on the other side of the state, because there's literally nothing. Now, Connecticut Hospice, I've heard that they are going to try to start doing pediatric hospice, and I heard that might be in 2 to 3 months. So, you know, that would be something, you know, that would be really, really helpful. But again, yes.
Thanks, Tony. And to circle back to websites, I think a part of the issue is communication and to some degree marketing. So whatever the central location is, our providers are not saying in acute care may not be saying, here's a flyer on XYZ website. It has this, this, and this. Some of it is regarding linking, as you suggested, maybe the case manager to introduce, here's what's available, here are your next steps in a practical way. And that then that points in the direction to where the resources are, where the supports are. So I think that's really important, not just to build another website. It's the
Right.
communication to the families.
Mhm.
Yes, 100%. 100%. See, now I just Googled it, right? I just put it in and I said, I did ChatGPT and it said, how do I find pediatric support for my chronically ill or terminally ill child in the state of Connecticut? And it says Connecticut Children's, Sunflower Kids, Regional Hospice, referred simply as Regional Hospice, okay. Children Development Info Line. I'm not even sure what that means. And then it says, when contacting a hospital or hospice, ask specifically for pediatric palliative or hospice care. So yeah, I mean, I just wanted to do it just to see like what came up. But I agree. Go ahead, Melissa.
Part of effectively managing a virtual footprint is constant content management, proactive pushes. I had a very long conversation with my niece because she's a communications and a marketing expert. She gave me really, really long, like email marketing, mobile presence, apps. There's lots of ways that, people at the age range of these parents look to for sources of information, but a lot of it is, putting time and energy into curation of content, aggregating other sites, aggregating other information, and creating the tools, and also getting that into the hands of practitioners, whether it's a case manager, whether it's an oncologist, pediatric oncologist, whether it's, a hospice nurse, so that they also have access to this to know how to guide their clients. So
Right.
it's not once and done. It's continuously and constant. And so that's why having, something that has breadth and depth and management behind it is incredibly important. I think, to Eileen's point of, there's a lot of stuff out there, but some of it is, you have to have people who are going to continue to make this their primary role, to continue to push information, manage it, and coordinate it with the appropriate practitioners.
Yes.
And Barb, you
agreed.
had your hand raised, I think.
I just have a quick comment, Melissa and Leanne. Do we not have representation from certain areas that we should connect with? So Regina has mentioned 211. Do we need to have some outreach to 211 to see or understand the scope of the work that they're doing? Do we need to reach out to insurance to understand better that process, and if there's the potential for parity across the payer spectrum, and then anyone else that we have not thought of? Because
Yes.
I hate to be that proverbial clock, but it's tick-tock, and we need to get a report. And Melissa and Tony Ann, your leadership has been amazing. So we are grateful for that, and you are keeping us focused.
And I think that would be great, because honestly, like when you say 211, I think of mental illness emergency, like when you call 211. Is that the same as the info 11?
I am not a subject matter expert. I'm going to look to Regina on that.
Yeah, so no, the Info 211 website is pretty much a hub for, community services and it's statewide. So, and I understand they've updated their website quite recently. So when you log on and you go through, it just gives you a slew of resources in the community and how to contact and get to them.
Was that the site that you were referencing when you first started talking, Regina?
Yeah, it's
Okay.
info 211. Yeah, I
Okay,
said
thank
info
you.
11 is info
Yep.
211.
Yep.
And
we contacted them and worked with them a lot during COVID. So there's a real willingness to work with stakeholders and partners.
And do we think I mean, I can get in touch with my lobbyist. He said he could get in touch with the lobbyist, and I can't remember her name right now, who works with all the payers. But is that the person we want to talk to? Or do we want to talk to someone who actually works for the payers? Like, what is the lobbyist going to be able to to tell us other than us telling her this is what we're looking at? Because I'm not familiar. Do you think that would be the way to go?
The lobbyists, typically, my experience with the lobbyists have been they are very well informed about the individuals that they are representing. So they have a very wide base of information, but we may also want to consider if we need to work with the State Department of Insurance as well, it's certainly a different representation where the lobbyist is representing the payers' needs. The Department of Insurance is representing a very broad scope, and it's 3.6 million beneficiaries in Connecticut they represent.
Okay.
Barb, who do we talk to get that contact or that information?
I have the lobbyist.
Oh, okay. I'm sorry.
I have the lobbyist. As for the State Department of Insurance, that I don't know.
Okay.
I will ask, and I can send, if I can get a contact name, I will send it to Melissa, Tony Ann, and Dr. Moss.
Okay, perfect. Hello, Dr. Moss.
Hi,
Yes,
friends. Sorry, clinic demands today just got a little out of control.
Yeah, that's
Those children that need, so a filming crew showed up at, to do this expose that I wasn't even aware of today. So it's been quite a day. But
oh wow.
Sorry, what did I miss? Catch me up.
Nothing.
And I'm sure you did. I'm sure you did just fine. Well, just to give you a quick recap, we've just been going on like the expectation of this report and the expectation of a pilot program. And we just don't think that a pilot program with certain barriers still in place, other than a pilot of what education with nursing rotations could look like, is really something that we can put forward. I think we're going to have to put like recommendations and things like that. And, we know the things we want to hit, and I just don't think we have the meat for a pilot program that would be providing palliative and hospice care to pediatrics right now, because the barriers are the barriers, and we sit in them today like we did last year and 10 years ago. So I think trying to move forward with recommendations, and then even other things like what we have talked about with you, how do we get those other things done? Is really what I think, we need to present.
Yeah,
I would also say we don't have to accomplish all of this right now.
Right.
I think we have to tell them what we'd like to do. I think some of it is about what monies we would need to make these things happen, and then create a timeline when we think certain things will be prepared to start. And the fact of the matter is, we really only started talking in September, and it's now mid-December, and we've made tremendous progress, but we need a lot more lead time on some of these things in order to make sure we get it right, at least to start with, even to step out into starting actions on things. So
I think I agree. At what point do we think we actually ask for the funding to start some of this? Like that, I think, we could just keep doing what we're doing, and we really do need some funding if we're going to make the mark with this. And so
they want the February 6th report to include proposals for funding.
Proposals for funding in more of an immediacy sense, because I think ultimately, as we step back, we need to think about the fact that if any of this work is going to continue, there's going to have to be recognition by the state and funding allotment for it. Like that's the part that I feel like we haven't put too much time and emphasis on yet, but I do think we need to is, and I was thinking about this today as kindly as, these meetings are weekly, right? And there's a lot that we're putting in time and energy. And so what does this look like in terms of the allocation of funding to continue this work? And so just
right.
I think we're talking about funding for 2026, assuming that they concur with what we'd like to accomplish. But for example, one thing might not start till March, something else might start in September. So there's probably staggered approaches to certain things that we want to move forward for this proposal.
Well, and I think we have to realize, if I'm correct, the fiscal year for the state is 27 right now. No,
26.
26. Right. Okay. Because I'm like,
Yes.
wait a minute, I've lost my
Yeah.
mind. Right, is already 26. So what are the things, that we are going to need funding to do?
Right.
Yeah.
Yeah. So I think there's hopefully we can create a timeline to say, okay, in X month of 2026, we'd like to begin this. And I think one thing we mentioned earlier, Dr. Moss, was the fact that some elements of what we'd like to accomplish are in, more advanced stages of maturity. Like right now, we already have hospice resources out of regional hospice, and we have the palliative hospice care from Connecticut Children's Hospital and Yale New Haven Hospital. So we know that they're ready to start to deliver, or they're already delivering services. But for example, if we were to create kind of a dedicated virtual presence, we may not be able to start that till this late summer, early fall, something around that timeline, once we know what we want to say. So, and I'm just throwing that as an example, and not that we've
Right.
included that, but
Okay. Yeah, I think there's so much. It's amazing the amount of work. I think that I think we all share the same test, but that we are. Every time we look, we just kind of seem to uncover more work,
yes.
more opportunity for work, and I think at times that gets a little daunting. But I think it's amazing to see these things coming together, and I actually think the ongoing engagement and enthusiasm is probably the most striking thing. Like, we have tried
Right.
for years to establish things that would allow for this consistent communication, and this has been the first time that we've really actually been able to do it. So that's really heartwarming.
And one of the things we're going to ask is for this committee to be approved to continue, because we're all quite a lot in sync. And assuming people still want to continue to participate, we have great thought leadership here and a lot of arms and legs in the field who can actually take action and mobilize. So.
When they say a pilot program for Champion Care, is that something that we break out into? And I know you put this together, Melissa, but is that something that we put and break out into how much that's going to cost us to pilot something called Champion Care with someone answering the phone that is going to have maybe referrals for pediatric and palliative care? Like, do we try it in small bites that way? Because, the expectation is that we're piloting Champion Care, and within Champion Care is a pediatric, palliative, and hospice program.
Mhm.
So
I think we have to think about what's the optimum model. We may not, when we talk about a pilot, we may not be able to start the pilot officially
right.
until November of 2026, right? Because we're not prepared to do that. I think that, the question is what do we need to build? What are resources we need to engage? What's missing? And then how we'd like to start this. But there's components of what we want to accomplish that can start as soon as we get approval.
Right. And maybe there's even a component in Champion Care that includes pronouncement in a home, that if you're not on a service for hospice, or can you, so if you're on palliative care, though, we could pronounce, right? Yeah.
Hopefully you're not asking me.
No,
No, I was
absolutely.
looking at Dr. Moss. I'm sorry.
Oh yeah,
Okay.
you don't have to be on hospice for nurse pronouncement. In fact, you can be on skilled nursing. You can be on skilled nursing visits that is designated nothing else. You just need a nurse that's willing to pronounce.
Right. Okay. And that, when you say skilled nursing, that could just be your typical home care nurse that comes out and does a pronouncement.
Correct. It's generally my experience is that most shift agency companies, so your Avianas and your All Points and those companies that do shift nursing, they do not do nurse pronouncement. Their organizations do not, and their nurses do not do nurse pronouncement. So nurse pronouncement comes as in point to a skill. And so what ties it to palliative is that it's hard for a nurse who's not doing another skill in a home to then come in for pronouncement. So we like to think of it as palliative and or hospice, so you get a relationship with the family and such. But the true brass tacks of it is that you need a home care nurse that's willing to go into the home and do the pronouncement on behalf of a physician that will sign behind. That is really what is required.
Right.
Harry, just to follow up on that, is it because of the discomfort on the part of the nurse, or?
The discomfort meaning of the home care agencies that no, it's deemed a conflict of interest. And so it's been come back as a conflict of interest to pronounce the patient. And so they do not by practice. I mean, sometimes it's the fact that I'm going to show my ignorance. I don't know if LPNs can pronounce.
No.
I believe it is only RNs. And so some of your skilled nursing, some of your shift nursing companies are filled with different various levels of training. And so that is part of it, is it may be that you don't have that you may not have, you may have an LPN in the home and not an RN at the time. And so they wouldn't be able to pronounce this, but that has never been, it's not been about, I've never heard, we don't think it will be someone of the skill level or the scope level. It's more about conflict of interest, and just that is not what the service we provide. So I've never, in my experience, which may be limited and different from others, I've not had a shift nursing agency be willing to provide a nurse pronouncement for me.
So even if the kid dies while the shift nurse is there,
they don't do the pronouncement.
Oh, okay. Okay. Do you all mind? And I feel like we keep pulling up people that could educate us more and things like that. And I know we're held to a date to get this report, but I also think that maybe Allison Blank, who does Western Connecticut Home Care, and they do pediatric home care. It might be interesting to hear from her and her perspective on pronouncements and things like that, and just see if that's something that we could include if we were doing champion care, that if home care could also be included, pediatric home care could be included in pronouncements. Oh, Jessica Pope, I see you there with your hand up.
I am here. So sorry that I was late to the meeting, everyone. For the home agency pronouncement, my understanding is very similar to Dr. Moss, that this is typically seen as a legal constraint because of the conflict of interest, and also liability on the home care nursing side.
Okay.
I don't know all the ins and outs, so I can't say for sure that that's not a possibility, but in my experience across multiple states, that's pretty consistent from the feedback,
Okay.
and that typically it has to be a palliative or hospice agency that's providing the pronouncement because of the manner of involvement, and also that physician backing. Most home care agencies don't necessarily have the physician that's working as part of the plan of care that can sign off on that. I also don't know the constraints of the death certificates in Connecticut. I know that there are states that have very specific guidelines surrounding who can sign the death certificate, what has to be submitted. So that might also play a role in some of that as well. And then I also just wanted to comment, for my own understanding, we're really looking at establishing or proposing a framework versus proposing a pilot. Is my understanding correct based on our conversation today?
Well, I think we should change the wording from a pilot program to a framework, to be quite honest.
So a framework for a pilot program.
I think that just allows there to be less
Right.
pressure on really putting something forward and starting something, but still promotes that end goal of offering expertise on how a champion program would function and what it would look like.
I think that's fabulous.
I also think the framework allows us, the framework to pilot bridge allows to say the pilot really does need the funding to come through. I mean, I'm not sorry if I'm harping on funding a little bit today, but I keep thinking like if all of us say, you know, I have too much patient care and I can't do this anymore. All of us, because we are all doing this kind of in a very volunteer capacity in this moment, then all of our work is for naught if there's not a sustainable funding opportunity for people to want to carry this work forward, right?
Right.
Yep.
Like you have the true dedicated that are doing this work right now, but ultimately for this to be sustainable, there has to be a system that maintains it, that has some funding for it. So I think it'd be nice to get the funding to then move to the pilot, because that would be, to do the pilot without funding is just probably proliferating the issue we have in this, which is that we all do this work without the proper reimbursement for doing it.
Right.
Is there anybody on this team who would not be able, not that you wouldn't want to, but would not be able to continue participating? And maybe the format of what we have going forward is we don't have to, it can be less formal or less frequent, but is there anybody who is not able to continue as a member of this group?
No, I think I would really love to see us limit it to 2 times a month moving forward.
Yeah.
Just from a scheduling standpoint, it's just current. I just have a whole slew of new oncology patients, and so it's a little bit challenging for me currently.
Well, stop taking care of those kids, Dr. Moss.
Oh my gosh.
God.
They're just adorable humans.
Oh, Lord.
So cute.
Okay, and I do see it's 1:59. I think I would like, and Dr. Moss, you can let me know your schedule. I think it might be best if I'm happy to do it because you are much busier than me. But if we give Senator Anwar and Representative McCarthy-Vahey a little bit of a heads up of where we're at and what is going to be coming forth, just so that at the advisory meeting, it's not a surprise. Anybody have thoughts that that's not a good idea? Barb, you're the most like in on these, like when you're giving report outs and stuff. Do you think we should give them a heads up before we're on the meeting with 25 other people?
I think it is. I'm trying to get back to, I know you can't hear me.
No, now we can.
Yeah.
I think it's always a good idea to update as much as you can to the 2 legislators who are genuinely interested in this work. So my vote would be yes. Okay.
All right. So I can work with you, Dr. Moss, offline on what that could look like, even if it's a 15-minute, conversation.
And Tony Ann, will you include the recommendations coming from Eugene's group, the Solomon Center, regarding the SPA or the waiver, any of that, or no?
In the phone call that we'll have with the senator and the representative.
Yes.
I mean, I think I'm going to leave that to Barb too. Do you think that's a good idea? Because I'm happy to just give a heads up of what's coming forward. I just don't want them to think that in a matter of weeks they're getting this, well-polished pilot program of, X, Y, and Z.
I am always of the mind that it's better to over-socialize.
Okay.
Any issue.
Okay. So yes, Eileen.
Thank you.
Okay. All right. And so I'll work with Dr. Moss in the background about that, but I'd really like to do it before they're on the call which I think is next week.
It is
the 17th.
Mm-hmm.
And then we can go from there. And maybe the perspective kind of changes and they say, okay, well, if that's what you're working on, then give us blah, blah, blah. I don't know. But I think we need to have the conversation sooner than later and not be a surprise with a boatload of people.
Well, and I guess my question is, I mean, I just have to admit I have a conflict next Wednesday that I wasn't aware of, but I know we were trying to maintain that meeting really to just keep people feeling involved and engaged. It's just I wonder if we really have much to give on that meet. Like, how much are we looking for? And with the holidays and stuff, do we want to? Because we're scheduled to meet on the 7th, right? I need to send you out the invitation to come, but I feel like we really after that meeting we're going to have a lot to share.
Yeah, so maybe that's a good idea. Maybe we'll just cancel the next one.
I mean, in terms of like reporting out to that group as a whole, I'm not sure that we are in a position to have a real report out.
I think that's a good point.
I want you to have it. I recognize that my schedule will not allow me to be present. I'm not telling us necessarily to have it. I'm just wondering if in the best use of time and thought process that we really don't have much for that we want opinion on at this point. And so I'm just not sure that time will be as well spent for everyone unless someone respectfully disagrees.
I think that we can absolutely cancel that meeting, but I still think then before the next one, we should have a call with Senator Anwar and Representative McCarthy Vahey.
Agreed.
Maybe you can use that time next week that's already scheduled on their calendar to just give them
Dr.
15
Moss
minutes
has
of
a conflict.
I have a
I'm sorry.
conflict, but I'm
Sorry about that.
whatever works best for others.
Okay, no, we'll wait. We'll cancel next week, and then I'll still put on something after I talk to you, Dr. Moss, about the possibility of meeting with the two of them.
I'm sorry,
Perfect.
guys. I need to hop off to another meeting. I was hoping
Go ahead.
Thank
Yeah, I
thank
know.
you,
We're
as
Regina.
well.
chat, but I
done.
couldn't see it.
So.
Okay.
Okay.
All
Right.
Bye.
All right. Thanks, everyone.
Thank you, everybody.
Okay. Bye.
Happy
Right,
holidays,
bye-bye.
friends.
Happy
Yes,
holidays.
thank
Hey,
you.
bye-bye.
Bye.
Bye.